Okay, let's talk about heart failure. Heart failure is a clinical syndrome of cardiac pump dysfunction that leads to congestion and low perfusion. Symptoms include dyspnea, orthopnea, fatigue. Sign include S3 heart sound, Rales JVD, which is jugular venous distension, and pitting edema. Okay, so what is orthopnea? Orthopnea is basically when you have shortness of breath, worse when lying flat. So you have simple, in other words, SOB, shortness of breath. When it get worsens with when you lie flat, right? That's orthopnea. And what is one more thing is called paroxysmal. Let me just write that down here. Paroxysmal nocturnal dyspnea, and that is sudden worsening of sudden worsening at night during sleep. So dyspnea, which is a shortness of breath that suddenly worsens at night during sleep, that's called paroxysmal nocturnal dyspnea. Okay. So wait here 1 second. So that is what we have for orthopnea and a PND, which is paroxysmal uh, nocturnal dyspnea. This orthopnea, this will develop over minutes. So high yield that you will see in the question stems are the patient uses pillows to sleep comfortably. So the patient use pillows. They use putting pillows, or they're putting pillows on under the head, or they're trying to um, put the pillows down so they can have an angle in which they can sleep to sleep comfortably. Because of shortness of breath, they can't sleep, so they have to use the pillows. So that is a very hallmark of your orthopnea here. Okay, so now let's talk about systolic dysfunction and diastolic dysfunction. As we mentioned before, uh, systolic dysfunction is going to be heart failure with reduced ejection fraction. So that's low. So systolic dysfunction, low ejection fraction, eccentric hypertrophy. Exactly here, systolic dysfunction, reduced ejection fraction, and they haven't mentioned here, but you can also have this is due to the fact that you have eccentric hypertrophy. So that they named it here as HF, heart failure, reduced ejection fraction. With that, you will have increase in end diastolic volume, because you remember you can't push the fluid out in systolic dysfunction. You can't push the fluid out. So because you can't push it out, you're gonna increase your end diastolic volume, meaning at the end of relaxation, the volume that you would have that would be increased because you couldn't push out in systole, because of you already had a problem in systole, that was systolic dysfunction. When you couldn't contract properly, called dysfunction, more fluid is going to retain, causing increase in EDV and diastolic volume. Decrease in contractility for sure, because you can't have systole contraction. That means there's decrease in contractility. Important thing is, why did this happen? It happened secondary to ischemia, or MI, or dilated cardiomyopathy. So ischemia, MI, or dilated cardiomyopathy. Let's compare this with diastolic dysfunction, which is heart failure with preserved ejection fraction, HFpEF, heart failure, preserved ejection fraction, normal, because you have systole normal, meaning you can contract the heart normal, so you will not have more volume here because you have a normal contraction. So that leaves you with and diastolic volume would be normal, because it is not the contracting problem, it's the relaxation problem, right? But there will be decrease in compliance because you can't dilate it normally. So there will be decrease in compliance. And that compliance would lead to increase in end diastolic pressure to be high. Okay, so there's going to be a diastole, meaning the balloon can't open. When you can't open the balloon, the pressure is going to be high. So the pressure EDP, which is end diastolic pressure, will be high because you can't open the balloon because it's a diastolic, meaning you can't open it. Secondary to why this happened is because of myocardial hypertrophy. Okay, myocardial hypertrophy. Now another story. The next point is right heart failure most often results from left heart failure, high yield. Again, the wording is right heart failure. So this guy, right ventricular, fails most commonly from the left heart failure. Cor pulmonale refers to isolated right heart failure due to pulmonary cause. So if the right heart failed due to some pulmonary cause, we would call it cor pulmonale. Okay, so now let's look at the drugs, ACE inhibitors, ARBs, and angiotensin receptor, neprilysin inhibitors, beta blocker, except in acute decompensated heart failure, and aldosterone receptor agonist. High yield, they all decrease mortality in heart failure with a reserve ejection fraction. So they all decrease mortality. Okay, so loop and thiazide diuretics are used mainly for symptomatic relief. Hydralazine with nitrate therapy improves both symptoms and mortality in select patients. So important point again is this point that you decrease mortality by giving ACE, ARBs, neprilysin inhibitor, which is sacubitril, beta blocker, aldosterone antagonist, and sodium glucose cotransport inhibitors. All of them would decrease the mortality. Okay, now let's talk about the actual left heart failure signs and right heart failure sign. So left heart failure, let's just change color here. We used okay, left heart failure. So for the left heart failure, you have to remember with just one mnemonic for left one is going to be L for left, right? Left heart failure. And L for lungs. So lungs are involved. I mean, if you think about it, the lungs are involved, but just sometimes the mind doesn't work, so mnemonics work. For that time of period, you will just say L for lungs. So whenever there's a left heart failure, lungs, there you will see things in the lungs. Okay, the problem will be in the lungs also. So let's talk about those problems now. Orthopnea. Again, we talked about the orthopnea, which is a shortness of breath when supine, increase in venous return from redistribution of the blood, immediately gravity effect exacerbates your pulmonary vascular congestion. So what do patients normally do? They put on the pillows, try to increase the posture so that they don't go into having exacerbation in the pulmonary vascular congestion. What else? Paroxysmal nocturnal dyspnea. Okay, we did talk about it as well. This is the same thing, but what it is, it's a breathless awakening from sleep. Nocturnal, right? Nocturnal dyspnea. You have a shortness of breath in sleep, so you're awaking because of that. And why does this occur? It occurs because you have increased in the venous return from redistribution of blood, leading to reabsorption of peripheral edema. Okay, the last one is pulmonary edema, high yield. What is pulmonary edema? You have increase in pulmonary venous pressure that causes pulmonary venous distension and transudation of fluid, presence of high yield hemosiderin laden macrophages, heart failure cells in the lungs. how are they going to say these guys look like hemosiderin-laden macrophages? Well, they will look like golden brown cytoplasmic granules. So golden brown cytoplasmic granules. You know, they wouldn't just mention the whole thing because this is a key wording, right? So in in the pulmonary edema, there were some golden brown cytoplasmic granules are found on the histostain. So what is this? Cytoplasmic granules. Okay, one more high yield point that I would like to mention here is that this is not acutely. So as you know, hemosiderin. So for the hemosiderin-laden macrophages, so for that, you macrophages have to come, and then after coming to that place, they will eat up the dead cells, causing hemosiderin, and then engulfing would cause hemosiderin-laden macrophage. It will take time. So chronically, you will see it. But what will you see acutely? Yeah. So in acute phase of pulmonary edema, you will see acellular pink material. Acutely are going to be acellular pink material. Acellular pink material will be seen, and it is due to the presence of intraalveolar transudate. So this transudate from the engorged alveolar capillaries. So again, let's just highlight this point. In pulmonary edema, acutely, because of this transudation of fluid, you will see acellular pink material. But again, in chronically, hemosiderin-laden macrophages, which are specific heart failure cells in the lungs. And what are the macrophages, hemosiderin-laden macrophages? They are golden brown cytoplasmic granules within the macrophages. Okay. And why did this transudation occurred? Let's just erase this point here. Why this transudation occurred? Well, transudate always occurs when you have increase in hydrostatic capillary pressure. When you have increase in hydrostatic capillary pressure, it causes transudation of the fluid into the interstitium. Okay, and that is going to be all. So let's just review this quickly. For left heart failure, what do we have? We have orthopnea. One more thing for orthopnea is going to be dry cough. Dry cough. Orthopnea, dry cough, shortness of breath when supine. Paroxysmal PND, paroxysmal nocturnal dyspnea, shortness of breath that would awaken you from sleep. Pulmonary edema, due to transudation, you will see acellular pink material, and then later on, chronically, you will see hemosiderin-laden macrophages, which are the golden brown cytoplasmic granules within the macrophages. And that is going to be it for the left heart failure. L for the lungs are involved. For the right heart failure, what do we have? Right heart failure is going to be lungs are spared here. Okay, so we will see everything else except lungs. So congestive hepatomegaly, because of increase in central venous pressure, there's going to be increase in resistance to the portal flow. Rarely leads to cardiac cirrhosis associated with nutmeg liver. So what it is basically there. So you have right ventricle, right atrium, right, and right heart is failing, meaning it's not pumping the blood out of it. So everything will backflow. So the backflow is going to be where? It's going to go up, right? So when the backflow goes up, it's going to distend the JVD. So it's going to cause JVD, right? Jugular venous distension. And when it goes into the IVC, it's going to give you two things. One thing is peripheral peripheral edema, and on the other hand, you will also get congestive hepatomegaly, which is known as nutmeg liver, right? So this is exactly what is here. You have congestive hepatomegaly because increase in central venous pressure, because the pressure is increased. Why? Because the right heart, it can't push the fluid out. When it can't push the fluid out, it's just gonna go into backflow into the two main vessels, two main veins, which are coming to the right atrium, which is superior vena cava, inferior vena cava. So it's going to cause increase in central venous pressure. Increased central venous pressure causes increase in the portal flow, which rarely leads to cardiac cirrhosis. Also associated with nutmeg liver, which is malted appearance on the cross examination. JVD, increase in venous pressure, that causes JVD. Peripheral edema because of increased venous pressure. Fluid would transudate. Again, transudation is increase in PC. What is P? Hydrostatic capillary. What is C? Capillary pressure. So hydrostatic capillary pressure. And that is going to be all for right heart failure. Remember, right heart failure, no lungs involved. So the question goes back to this, what they said up top. They said if you have a problem from the lungs, let's say you have a lung involvement that causes right heart failure, what are you going to call? Col pulmonale. Right here. Col pulmonale refers to isolated right heart failure due to pulmonary cause. Okay, so let's now, in this picture we haven't looked at, this is pitting edema. As you can see, there is pitting. So pitting edema. Okay, now let's look at this image. Okay, what do we have here? We have, so let's start with decrease in cardiac output that would cause increase in sympathetic tone and also increase in renin angiotensin aldosterone system. So RAS would get activated and the sympathetic tone get activated, just the fact that you have a low cardiac output. So let's look at the sympathetic first. That increase in sympathetic tone would cause catecholamine beta 1 stimulation and alpha 1 stimulation. For the beta 1 stimulation, you're increasing the contractility and increasing heart rate. With alpha 1 stimulation, you're causing vasoconstriction. And that vasoconstriction will lead to increase in vasoconstriction, meaning increase in arterial tone, which would maintain the blood pressure. Increase in heart rate also causes maintained cardiac output. That would also maintain the blood pressure. And increase in contractility would also lead to increase in stroke volume, again maintaining blood pressure. What are we trying to do with all of this? We are trying to get to maintenance of our blood pressure. And whatever we're doing, we're just trying to keep that blood pressure maintained. So with the sympathetic tone, we're trying to do that. For the RAS, let's see how. So RAS, with the RAS activated, angiotensin 2 and the ADH both will cause vasoconstriction. And with the vasoconstriction, you have two things: increase in arterial tone and increase in venous tone. That increase in venous tone would lead to increased venous return. That increased venous return again causes increase in stroke volume and maintaining cardiac output, essentially going to maintain blood pressure. For on the other hand, RAS with the angiotensin 2 and aldosterone and ADH working on V2 receptor, that is going to be increase in circulation volume. So V1, again looking at the ADH receptor, V1 is on the vessels, while V2 is in the kidneys. So with the kidney, antidiuretic hormone will try to reabsorb more water. Antidiuresis, as the name says, antidiuresis, no more diuresis, no more urine. So get the volume back. So it will try to increase the circulating volume, while on the other hand, ADH on the V1 will just vasoconstrict. As well as the angiotensin 2 is also working on the vessel, causing vasoconstriction. And angiotensin 2, aldosterone, and ADH, all of them are causing increase in circulating volume. that would again cause increase in venous return. That will lead to increased stroke volume, maintain cardiac output, and maintain blood pressure. So this whole is hemodynamic stress, and that was neurohumoral stress. Neurohumoral meaning simply that you have these hormones that are working um, and causing the actual thing. And hemodynamic is basically in the circulatory system you're looking at, and that is going to be all for this thing. On the left side, you also have two small graphs. So let's talk about these as well. So the first one is heart failure with reserved, R is for reserved ejection fraction. So where did we talk about this one? For reserved HFR, EF, this is the systolic dysfunction, right? So this graph is for systolic dysfunction. And if with systolic dysfunction, as you know, if you look up top again, there is a decrease in contractility. If you go back, what would they say? Decrease in contractility, right? So now here it's just that it is shown in a diagram that how decrease in contractility will be seen. So if the black is normal, with the decreased contractility, what do you see? So you have line that is here, and the whole graph is shifted towards the right side. And this is all about your decrease in contractility. What else would be there? But if you look here, this is preserved. Note there is no change here, right? So this is preserved compliance. So now let's compare this with the other graph, which is called heart failure with preserved ejection fraction, which is seen in diastolic dysfunction. If you look back up here, it's right here, diastolic dysfunction, HFP, preserved ejection fraction, right? Diastolic dysfunction. So here what's really happening is you have contractility, which is normal, but you have compliance, which is low. So over here, you had a low contractility, preserved compliance. Here you have contractility normal, but compliance is low. When the compliance is low, look at the graph. The graph has shifted up, and that is basically the compliance. So if you look up again, you will see that in your diastolic dysfunction, you will have a low compliance, and with increase in EDP, and I will show you how that is increased here. So this was the normal EDP, end diastolic pressure, right? This is normal. So now the end diastolic pressure is raised. So end diastolic pressure became here when you decrease the compliance. Okay. And that is going to be all for this thing, heart failure.